This is Joshua Levine. Welcome back to the Neurocritical Care Society podcast. In this episode, Dr. James Siegler interviews Drs. Yogendrakumar and Deutsch Najee on their article, Lack of Early Improvement Predicts Poor Outcome Following Acute Intracerebral Hemorrhage. It was published in April 2018 in Critical Care Medicine. Here's Dr. Siegler.
Hi, my name is Jim Siegler, and I'm from the Hospital at the University of Pennsylvania. I'm joined this month by Dr. Yogendrakumar and Dr. Deutsch Najee. Thank you both for joining me on the NCS podcast.
Thanks very much.
Thank you.
Let's begin with the context for your study. Dr. Yogendrakumar, can you briefly describe the impetus for the investigation and why you chose to look at patients with ICH?
Yeah, sure. So the major motivating source for this study was really trying to evaluate the concept of early neurological worsening. So that's defined classically as a change in your NIH stroke scale of greater than or equal to 4 when you compare a baseline assessment to a follow-up assessment, usually at the 24-hour mark. This definition has been utilized both in ischemic stroke and in hemorrhagic stroke literature, but what we found is that it had not been sort of formally validated in the hemorrhagic stroke population. And this is important, especially in the context of prognostication, which it has been used for. We know that early deterioration is predictive of poor outcome, especially in hemorrhagic stroke, but there's quite a bit of variability in what degree of worsening actually predicts poor outcome. So as such, we wanted to do two major things. We wanted to sort of validate the classic definition of early neurological worsening, but also use a data-driven approach to try and determine if there is a better predictor of early neurological change that can predict poor outcome for patients with hemorrhagic stroke.
Can you briefly walk us through the type of population you looked at and the methods that you chose to answer your research question?
Yeah, so we did this over 2 phases. So the first phase was a derivation phase. So we used data from VISTA, which is the Virtual International Stroke Trials Archive. So these are patients presenting with acute intracerebral hemorrhage. Effectively, our primary exposure was the change in the NIH stroke scale at the initial presentation and at the follow-up at 24 hours. So we looked at the difference between those two scores. And we compared it to our primary outcome, which was a modified Rankin scale range of 4 to 6. We built a receiver operating curve, looking at the exposure to this primary outcome. And from there, we utilized Uden's index to determine an optimal cut point. Uden's index was utilized because it balances sensitivity and specificity to the best way that we can go about. We found an optimal cut point in and around negative 0.5. So that clinically works with sort of a lack of clinical improvement.
And specifically, a negative 0.5, you're referring to the change in the National Institutes of Health Stroke Scale score.
That's correct.
For the listeners out there who haven't read the paper, you put together a research study that was based on a derivation and validation cohort using different patient groups. Can you describe these populations and what may or may not be different about the two and how this may have affected your results?
The VISTA population is primarily patients who have been part of intracerebral hemorrhage trials, and it's an accumulation of those particular components. So in contrast to that, PREDICT, which was where we did our validation analysis, was an observational cohort study. So PREDICT was individuals presenting under 6 hours with acute intracerebral hemorrhage. And so it probably represents a more real-world cohort as compared to VISTA. So there is some mild variation there.
Yeah, and if I can add to that.
This is Dr. Deutsch Najee.
One of the rationale for going in this direction, meaning starting with a clinical trial cohort and then ending in a more pragmatic real-life cohort, is for the final application of the study. If we derive in the strictest fashion using a quote-unquote clean cohort of clinical trial patients, which is to say those that had to meet a specific inclusion-exclusion criteria, we're coming up with a score that can then be used in a clinical trial. So that right off the bat, the derivation becomes generalizable for further clinical trials in ICH. But then that may not on its own be valid when you're dealing with the extremes of the ICH population, which is to say those that are not eligible in a clinical trial because they're either too good or very sick. So then we validate it in that real population, and in that way it can now be used for prognostication clinically. So it was a strategy to allow us to make this as generalizable as possible.
Excellent. Yeah, I thought it was interesting the way that you selected the two cohorts for that reason. My next question gets into how they matched up against each other as far as their characteristics. The patients in the derivation and the validation cohorts were pretty well matched for age, for their admission blood pressure, stroke scale score, and ICH volume, some of the major factors in the ICH score. However, when I looked at the adjusted odds ratios for the various thresholds of NIH stroke scale score change between VISTA and PREDICT, it seemed that stable or worsening neurologic symptoms were associated with a moderately increased risk of functional disability, whereas in the PREDICT validation cohort, stable or worsening symptoms were associated with an even greater risk of long-term disability. The overall message is still the same: a stable or worsening exam predicts long-term disability, but the situation seems twice as bad for patients in the PREDICT cohort. What did you and your co-investigators make of this?
I think that comes back to the generalizability of the study and the choice of two cohorts. Because in the PREDICT, we're dealing with a sicker population. So we're dealing with a real population with no exclusion criteria. I shouldn't say no. PREDICT, if you had known severe renal failure, for example, you didn't get a CT angiogram. So therefore, you couldn't get into the PREDICT study. So there are some exclusions, but overall it reflects the real life experience of ICH patients. So you're bringing in, quite bluntly, sicker patients, and then so you're having worse outcomes. So that's why the predictive concept still applies, which is to say, if you're getting better, chances are you're going to do better. If you're getting better early, you're going to do better. But you start out really bad, you're more likely to end out really bad.
I think it'd be an oversimplification to interpret the results of your study as indicative that stable neurologic symptoms are associated with poor long-term outcome in anybody with ICH. Did your group perform any subgroup analyses on patients whose 24-hour stroke scale score was no different from their admission stroke scale score?
So I think that's a fair point to make, and that's something we were interested in looking at. For example, in the VISTA cohort, of that population, 114 patients had no change in their NIH between the 24-hour mark and when they initially presented. Of those 114 patients, we found that about 54% of those individuals had a poor outcome at 3-month mark. We found very similar proportion findings in the PREDICT cohort as well. So when we looked at this particular population of those who got worse, even though they had no change in their NIH. So what I mean by worse, I mean long-term outcome-wise. We identified several risk factors for these patients. The presence of intraventricular hemorrhage was a major factor, higher baseline NIH scores, and increasing age.
And Dr. Najee?
I agree exactly. The message isn't that if you improve in the first 24 hours, you're guaranteed to do well, or that if you don't improve, you're guaranteed to do poorly. Basically, I think the message is that first presentation is not a stable presentation, in that it is not what you should be using to judge your outcome, or, very importantly, to offer prognosis to the patient. And we already know this from a variety of other studies that have approached this in different ways. We're just showing it in another way, that, look, there's a dynamic change that could occur in the first 24 hours, and that dynamic change may not be what you expected. You actually can improve in the first 24 hours, which goes against what a lot of the traditional teaching in ICH is. And if you don't improve in that 24 hours, that's a little bit of helpful information. I mean, if you started out with a really bad NIH, a lot of ventricular blood, improving a bit over the first 24 hours is good. You're going to do better, no question, but it doesn't necessarily mean you're going to be walking out independently. That first presentation is important, but your trajectory over the first 24 hours is equally important for prognostication purposes.
And speaking of that trajectory, among the patients who did improve within 24 hours, so they didn't have a stroke scale score change of negative 0.5 or worse, did you see what proportion of those patients were functionally dependent at 3 months?
Yeah, so in the VISTA cohort, 296 patients improved in the first 24 hours. Of those, 32%, so about a third, were functionally dependent at the long-term outcome marker. So simply put, even if you improve early, about a third of those individuals will still have some dependency down the road.
Neurologic deterioration after stroke has been a major focus of my own research since I was a med student, and most of the predictors in stroke are kind of obvious to the listeners. Someone who has advanced age, more severe deficits, larger territories of infarct or hemorrhage, anterior choroidal involvement. What new information would you say that we learned from the PREDICT and the VISTA cohorts, and what should our listeners take away from your paper?
A very traditional thing that you'll hear, perhaps overly nihilist, is when an ICH comes in, that the rate of disability is high, the rate of mortality is very high. This is about as good as it gets. We have no treatment. Things are just really going to deteriorate or stay the same. That's often a view that's expressed by many clinicians in the field. Not necessarily those that are experienced with ICH, of course. There you're going to hear something very different, that yes, absolutely disability and mortality are high, but sometimes if you can ride that out and get past that acute period, the patient actually can do remarkably well. And one thing is we know that the ICH patients take longer to recover. So perhaps a lot of the data that we have that gives us these pessimistic viewpoints are because they're based on the 3-month outcome that we typically apply to ischemic stroke. When you follow these patients to a year or so, some of them actually do remarkably well. So what is it about those patients, and what can help us predict that? So that's where we try to come. I mean, obviously we didn't go out to a year or 2-year follow-up. That wasn't our intention, but we're trying to say that, you know what? The change that you see in that first 24 hours is actually important. And it's not true that the majority of patients don't change in the 24 hours or worsen. Actually, we were surprised to find the majority improve in the first 24 hours. That was a new finding. And it was present in both our cohorts, that there's a significant amount of improvement that occurred in the first 24 hours. That is unexpected. So that's helpful information for 2 ways. One, from prognostics, you can now add one more piece to your armamentarium that says, let's wait. Let's do what we can supportively right now, and let's see what things look like tomorrow or in 2 days. Let's repeat the scan, reevaluate. So that's number one. But number two, it may actually give us a surrogate trial endpoint. When we're dealing with hematoma expansion therapies, whether it be hemostatic or hemodynamic, and some would argue there are some surgical roles in the early period as well. In your phase 2 trials anyway, you need a quick endpoint. And one that we would throw out there is calling it freezing the NIH, which is to say, if you have a patient that comes in with ICH and very early on, typically deteriorating as they come off the ambulance, come into the Hemorrhage, can we administer some form of therapy in the context of a trial and use as one of our outcome measures the freezing of that NIH, the prevention of subsequent deterioration in the first 24 hours? And in our study, we're suggesting perhaps even a slight improvement in the NIH in the first 24 hours. We're suggesting one could consider this as an outcome in an early phase 2 type trial, rather than investing in much longer outcomes, which you should probably save for phase 3 trials.
And Dr. Yogendrakumar, any other comments?
Yeah, I would echo the sentiments that Dr. Deutsch Najee mentioned. I think the key thing that I really picked out personally was sort of that there is a sizable proportion of patients that improve in the first 24 hours. I remember when I built the original receiver operating curve, and it showed that any worsening, no matter how little, was predictive of poor outcome. I remember looking at that thinking, well, that's not very useful information, because in my mind at that time, well, the majority of patients are going to get worse. But then looking at the data more deeply and seeing that in the VISTA cohort that up to half improved in the first 24 hours, and then seeing that also be replicated in the PREDICT cohort, that was a very surprising finding for me. It goes against some of the anecdotal components that I have when I practice on my own accord.
Okay. Well, I had a great time talking with you both about this interesting paper, and I think that your findings have a number of implications in how we think about our patients with ICH with prognostication. Thank you both for joining me.
Thanks a lot, Dr. Siegler.
Thank you very much.
This podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. The Neurocritical Care Society provides and advocates for the highest quality of care for patients with critical neurological illness throughout the world. Follow us on Twitter @neurocritical, on Facebook, or visit www.neurocriticalcare.org for more information about NCS and the comprehensive resources that it offers. On behalf of the Neurocritical Care Society, thanks for listening.